welcome to the Medicine and Science podcast from the BMJ. I'm Navjoyt Lada, standing in for Cameron Abbasi. On this week's podcast, we start with the UK. The Labour government has been in power for 18 months. We want to ask, how well are their policy priorities, as set out in the 10-year plan, aligned with patients' experiences of accessing primary care?
People who want an appointment to see their GP and the supply and speed of those appointments, but we know that access is more complicated. It's to do with whether people feel like they're a candidate for care, how they navigate services, how permeable they are. But policymakers often have this quite simplistic way of thinking about it.
And we'll hear why online gambling needs a different approach to regulation.
We should question whether it makes sense to us from a regulatory level, from a legislative level, or even just from a human level, to try and solve the problem of online gambling harms using proceeds that come in large part from people who gamble online and are being harmed.
We're 18 months into the Labour government here in the UK, and their changes to the NHS are beginning to be felt. In the 10-year plan that they launched last year, they announced 3 planned shifts for the health service. Firstly, they pledged to move care from hospitals to the community. They wanted an increased focus on prevention rather than sickness, and called for a shift from analogue to digital, with an improved NHS app where patients can access records, seek advice, and control some aspects of their care. But while these changes are happening, the long-standing issues with accessing primary care and getting a GP appointment remain a concern for many patients and healthcare staff. In a new research paper on bmj.com, a group of researchers have performed a qualitative study asking 70 patients and primary care staff about their experiences of accessing primary care in England. They explore how these changes are in line with or working against the planned shifts in the NHS 10-year plan, which you can hear about now in a special episode of the podcast. I'm delighted to be joined by one of those researchers. Hugh, can I get you to introduce yourself?
I'm Hugh Alderwick. I'm Director of Policy and Research at the Health Foundation.
And we have one of Hugh's colleagues at the Health Foundation, Louisa Pettigrew, who wrote a commentary to go with that article. Louisa, can I ask you to introduce yourself?
I'm Louisa Pettigrew. I am Senior Policy Fellow at the Health Foundation with Hugh, and I'm also a GP. I've been a GP for the past 17 years and still practicing.
We've asked you both to come on because we're talking about a research paper that we've recently published, which Hugh, you were a co-author on, and Louisa, you have written a linked commentary on as well. It's a research paper about access to primary care in England. Hugh, perhaps you can tell us, what were you interested in studying and why?
We wanted to focus on experiences of access to primary care in England. The context is we know that access to high quality primary care is the foundation of a high quality health system. It's the foundation of the NHS, but people's experiences of accessing general practice in recent years has fallen. And polling suggests making it easier to get a GP appointment is the top concern for the public. At the same time, we've got these big government plans to reform primary care, boost access, and it's got these 3 big shifts: more care in the community, more digital technology, and more prevention. And those have got implications for how you organise general practice. So the big objective of the study was to explore people's experiences of access to primary care and to try and analyse those experiences in the context of some of the big shifts in care that are already taking place in general practice in England.
And what were you hoping for that to tell you? You know, we have like surveys of patients and of staff, but was there something more that you wanted? Was it more depth? What was it that you were looking for?
Yeah, often there's a very simple understanding of access to general practice or other services. People think about people who want an appointment to see their GP and the supply and speed of those appointments. But we know that access is more complicated. It's to do with whether people feel like they're a candidate for care, how they navigate services, how permeable they are. But policymakers often have this quite simplistic way of thinking about it. So we wanted to do 2 things. One, understand what really matters for people when they're accessing care and how do they experience the current system. And 2, with the big shifts in the way services are delivered that government wants to take place, how does that fit with people's priorities for access? And given the system is already changing like this, more digital routes to access, care being delivered by a wider mix of professionals, what do people's experiences now tell us that policymakers need to do?
Okay, so tell us exactly what you did then. Who did you speak to and that sort of thing? What were your methods, if you like, in a nutshell?
Yeah, so it was a qualitative study, so trying to get in-depth experiences. We interviewed 70 people. That was patients, carers, and GP staff. That's GPs, but also others who worked in the practice. And we asked them a mix of things about a recent experience of accessing or providing services. So we focused on recalling a recent time that they either tried to get an appointment or struggled, but also delivered an appointment or tried to help somebody navigate services. And we talked about what happened, their experience, some of the barriers they faced, and their overall reflections on access and what mattered to them.
Okay, and you talked about how one of the goals was to try and map these experiences to the proposed at the time, shifts in policy with, more preventive care, more neighbourhood care, I think is the term they use, and more digitisation. So tell us then a little bit about what you found and how those experiences map to those kind of government focuses and priorities.
Yeah, the narrative is often that these three shifts are just a good thing. And the trick is, how do you do it? And how do we make it happen as fast as possible? We found a more nuanced picture. So there were some potential benefits of these new ways of working, but also potential unintended effects. So taking each of the three shifts in turn. So the shift to more digitalization in general practice, that's mainly things like online booking systems, access to medical information online. We found that for some patients that offered more convenience, easier way to access appointments, but it also offered new forms of exclusion. People struggling to use digital forms, having to do the same work twice, particularly for more disadvantaged groups. We also heard about the dehumanizing effects that can have on access. Some people really struggling to get their needs heard and understood. On the shift to community, that shift basically involves expanding the range of services available outside of hospitals, GPs working in bigger teams alongside a mix of other staff, often over bigger geographies. That's not new. The idea is to push this further. Again, people saw some benefits of that way of working. So greater capacity to make sure that people can have appointments quickly if it's a non-urgent need, to have GPs working across a larger geographical area to expand their reach. But we also saw complexity from a practice perspective, complexity navigating that system, coordinating across different practices. But for patients, a mix of potential challenges. I think chief among them, people worried about losing continuity of care with a GP they knew and trusted, which was really at the heart of what patients often wanted, feeling invisible and unknown in their practice, and sometimes having to travel further or again have more than one appointment when they wanted one with their GP. And the last shift is prevention. So unsurprisingly, practice are doing a lot of this already. Things like vaccinations, chronic disease management. People generally support the idea of prevention, but again, we saw concerns. So the risk that preventive interventions can fragment care, for instance, if they're focused on single diseases, single tasks, but also consuming capacity that could have been used for sort of patient-initiated consultations when demand for appointments was so high and capacity couldn't meet them. And staff also pointed us towards the bigger social economic factors that shape disease and the limitations of what they could do to make this shift to prevention happen. I think standing back, aside from the three shifts, we overwhelmingly found that the patients we spoke to wanted a sort of prompt, quick, easily bookable appointment with a GP that they knew and trusted. But that was often the most scarce resource on offer. And the big changes government's trying to make don't seem to change that equation.
As I was reading the paper, one of the things I was kind of taking away as I was reading it was that there does seem to be this disconnect between the policies, to some degree, the policies that or the directions that the government want to implement and what patients and practice staff seem to be saying. But at the same time, at least when you read the 10-year plan, some of what's in it is so vague that maybe it is the direction that, things will go in. But, certainly at the time the plan was published, it seemed that there wasn't the flesh on the bones there to know that for sure. As someone who's working in healthcare policy, what do you take away from this piece of research as being the kind of, key lesson or takeaway for you?
One, it reinforces what we already knew, which is that continuity of care really matters. People value it. And while speed of appointments is important for some patients, making it easier to access care is important. You've got to balance both speed and continuity. That's not new, but it's underscored through the research we've done. I think a bigger standing back point is we've got to define what general practice and primary care is for and make sure that policies are supporting that. So you look at, for instance, Starfield's 4Cs, general practice is the first point of contact. It's comprehensive, coordinated with other services. It's got continuity of care at its heart. Well, if those are your principles, some of these policies might eat away at them or fragment them. So at the heart of this is, what do we think general practice is for? And can we design services around that? I think the 10-year plan is a bit muddy on what general practice is for, and it risks fragmenting or eating away at the core offer.
Louisa, you've written a commentary that kind of is sitting alongside this piece. What did you take away from this piece of research? Was this kind of a familiar message for you as well?
Yeah, I really enjoyed reading this piece of research. It really resonated with me both as a GP and as a patient. I think one of the key messages was that what patients and public often value is human connection with a clinician they trust. And that really resonates with me both as a GP and a clinician. Having been a GP for the past 17 years, I've seen many of the things happen that sort of been described, the change in skill mix, which, while very welcome to some degree, has really helped with a whole variety of roles now in general practice. At the same time, these roles have had sort of a varying amount of readiness to work and a varying need of support in general practice. And inevitably, having to see different people for different things results in a fragmentation of care, and therefore is eroding continuity of care in general practice, which we know is so important. There's so much evidence suggesting that continuity of care is better for patients, is better for the health system, is better for the clinicians. So it is a bit of an issue. I've also seen sort of the growth of practices. It's increasingly less likely that you see the same patient, or you have patients that you know within your clinic. And the other thing that has changed over time is the working hours of GPs. One of the things that's really important to highlight is that we have more GPs now than ever before licensed. But when you look at working hours, about only half of them are working actually in NHS general practice. So we've got a smaller proportion of GPs than ever before working in NHS general practice. And we need to look carefully and think about what's happened there in terms of recruitment and retention. Although there's been some improvement in recent years, it is still a major, major problem. And myself, alongside many colleagues and peers in sort of my cohort, have seen gradually reduce their working hours due to burnout and find alternative things to do, whether it's research, teaching, leadership roles, private medicine, and some even leaving general practice altogether, which is really sad.
Yeah, I mean, that is one of the worries, that as the skill mix within primary care changes, general practitioners will be often seeing the most complex cases and patients, and that might kind of feed into burnout as well. Louisa, your piece was kind of cautioning against the unintended consequences of policies to improve access. I guess continuity of care is one of those things that we need to be wary of losing. Was there anything else you think that is important to kind of be aware of when considering policies to improve access?
Yeah, I think continuity of care is very important. I think, as Hugh mentioned, that access policies which erode what evidence suggests makes primary care effective, again, the continuity, comprehensive coordination care, first point of contact. If access policies erode those, then it erodes actually what primary care, what will make it effective. So it is a problem. I think the other issue that the study found was around potentially exacerbating inequities of care. If you've got digital access systems which are prioritised over other forms of access, such as phone access or walk-in access, then that inevitably may generate more inequities amongst the digitally excluded and crowd out, GP time or clinicians' time that they're focusing on triaging online consultations, as opposed to being able to deal with a whole range of issues that present to general practice.
Well, you mentioned the move to digital there, Louisa, and obviously that's one of the key pillars of the government's 10-year plan for the NHS. And maybe this might be a good opportunity to ask you two how you think the picture is looking. We recently published a news story that takes the temperature of the NHS and is looking at how the Labour government has performed in their first 18 months, and are they hitting the targets that they've set for themselves? And while it looks like things are moving a bit, we've got 1,000 more GPs, there are still major challenges facing the service. So, Hugh, what's your take on the first 18 months?
So 18 months into the Labour government, the big policy thing that's happened has been this 10-year plan. Now, the broad direction of the plan, things like boosting primary and community services, strengthening prevention, more coordinated care, they make sense. The public generally support those high-level ideas when you ask them about it. But those ambitions have appeared in a long line of policy documents over many years, and the plan is super light on detail on how that's going to be delivered. Resources are also thin. There has been an injection of money, and that's been a higher spending increase compared to other government departments. But when you look over time, the NHS has still got less than it's had in in terms of the long run average, far less than the last Labour government in the 2000s that had similar big ambitions for transforming care. So we've got this broad vision, which broadly makes sense, but not a lot underneath it in terms of the detail. And our study on primary care shows some of the unintended consequences when you get into the actual nitty gritty of what delivering those shifts mean. Meantime, you've also had actually a big reorganisation of the NHS that's been kicked off, despite Labour promising not to do one before they came into power. NHS England is being scrapped. Local planning bodies are being reorganised, and that's going to inevitably disrupt at a local level. So broad vision, potential for disruption. What's going to be the progress over the next 5 years with all of that going on? Well, it's likely to be on the one big political target for the health system that the Prime Minister set, and that's to reduce selective waiting times in hospital. There's been some progress. The elective waiting list is smaller. The modelling estimates differ, but it could be achieved with a real push. I think the risk is that it crowds out other ambitions for improving care and other ambitions to strengthen primary and community services outside of hospitals. There is inevitably going to be trade-offs because resources are constrained. And so we have seen a bit of progress there, and we could see enough progress to meet that target by the end of the Parliament. But we might be left with an NHS and the social care system that broadly looks the same at that point, despite being promised this radical reform of the health system. And there's some areas where we've seen very slow to no progress. Social care is a good example. With the glass half full, you might think the government's committed to reforming the social care system and has set up an independent commission to look at ideas for reform. A glass half empty, we've seen a long line of these reviews. It's a way to kick the can down the road and avoid reforming the system. Evidence of the past suggests we shouldn't be too optimistic. On prevention too, there's a big focus on prevention in the NHS, but actually we know it's services outside of the health system, it's social economic factors that really shape our health. And again, this idea of a health mission that the government had when they came into power hasn't really materialized. So a lot of big rhetoric. The question is what will be delivered, and I worry that the focus will be on elective waiting lists, which are of course important, but don't look like this comprehensive agenda that government's promised.
Yeah, they don't tell the full story. So, Louise, we've heard from Hugh about that kind of big picture across the health system. What's your reflections on, I guess, the state of primary care 18 months into this Labour government? And what do you think are the kind of most pressing considerations for the next few years?
I think probably what I'd like policymakers to consider is that general practice is more than a sum of its parts. I think this paper led by Carol Sinnott and Hugh and other colleagues highlight that continuity of care is slowly being eroded. And I think that there's a risk that primary care becomes very fragmented and transactional service rather than a caring service. And I think that's what makes primary care effective. So there's a real risk of that. I think in order to address that, we need to think about continuity of care much more carefully. I think we need to measure it. I think there is definitely work out there around trying to get it measured regularly in general practice. We need to raise awareness of its importance, both amongst the public and patients and amongst GP practice. That includes admin staff, reception staff who are often at the front desk guiding patients to their appointment. And we probably need to incentivize it, just being cognizant that when you incentivize something, there's always a risk of crowding out intrinsic motivation to do things well, and also there's always the risk of gaming. But we know from experience in general practice that if you incentivize it, it does get done. So it's worth exploring that certainly in the future. I think the other two issues are around workforce and funding. In terms of workforce, I've mentioned it already. I think we've got this absurd paradox where we've got more GPs than ever licensed in England, but fewer working in NHS general practice. And although there has been improvement in recent years, we've still got a long way to go. Our numbers of patients per full-time equivalent GP are pretty high for international standards. They're over 2,000 per full-time equivalent GP. That needs to be addressed. And we've got a situation where you've got GPs graduating that can't find work, or they're unemployed or underemployed. Half of GPs now are international medical graduates. There are issues around them being able to get visas and find work. And we need to look very carefully at retention in terms of the workforce, because there's a big loss of investment, all those GPs opting not to work in NHS general practice. And then finally, on the funding thing, I think Hugh's highlighted some of the issues. I think it's a perennial challenge where governments have repeatedly committed to moving funding from secondary care to primary care, but have currently failed. It is very hard to do. I think there does need to be upfront investment in order to deliver that shift. I think there's currently a Carhill formula review underway, but underpinning it is the suggestion that there is no additional resources. And I think if that's the case, it's being set up to fail, because if you have a redistribution where there's losers as well as winners, it won't be politically palatable amongst GPs and may lead to problems within the sustainability of general practice and patient care. So I think if you look at GP funding over the past decade, less is going into general practice as a proportion of NHS spend, although there is, if you look at the data, there is some increase in investment. Actually, what general practice is receiving is less as a proportion of NHS spend. And then with the additional resources channeled into general practice, there needs to be careful consideration in terms of how that's invested into general practice to make sure that's invested in a way that leads to better patient outcomes and better retention of the workforce.
Well, that's a lot for any government to be dealing with, but I think that's a reflection of many of the issues that we encounter and see. We've heard Q talking about there isn't really a strong vision for primary care within the 10-year plan. But Louisa, if you could, what would your kind of perfect vision for primary care look like if you had the reins of power?
Yeah, I think you're right to point that out. I think that the 10-year plan is a bit muddled in terms of what it wants from general practice, because on one hand, it talks about bringing back the family doctor. And then on the other hand, it talks about neighbourhood health services and integrated health organisations, but there's really a lack of clarity about where general practice will sit within those organisations. I think we're all anticipating or waiting for guidance around what neighbourhood health services will look like and what contracts will look like. And I think that's generating a lot of uncertainty within general practice. I think my message would be, if general practice is not on board, then the vision of having neighbourhood health services will not succeed, because you need to have general practice at the heart of those neighbourhood health services in order for them to be successful. And the government needs to think very carefully about how it's going to manage that alongside supporting existing general practice, and how that's going to integrate into these potentially new contracts, new models of care, integrated sort of neighbourhood health centres as well. I think there's lessons from the past where efforts to integrate primary care vertically with hospitals or other organisations have failed in the mid-2010s. And similarly, there's lessons around the problems that we had with Darzi clinics and walk-in centres causing duplication, confusion for patients, and something that was quite costly and not very effective. So I think we need to look carefully at the past and learn from those lessons.
What do you think that means, Louisa? Do you think that means having GPs and practices more involved in how these things are rolled out?
Yeah, I think general practice absolutely needs to be at the heart of discussions about how these neighbourhood services are going to be shaped and how they're going to be delivered. I think it's going to be a problem if they're not. And in order for them to do that, then there needs to be the time and the space and the resources for them to be involved in these conversations in order for them to be successfully implemented.
And those papers, Experiences of Access to General Practice in England and Policies to Increase Access to General Practice May Have Unintended Consequences, are available now on bmj.com. Over the last decade, we've seen a growth in gambling around the world. Governments have eased restrictions on gambling generally, but particularly on online forms. From sports betting to online casinos, online gambling has exploded. A new paper on bmj.com argues that governments need to take new approaches to regulating this online gambling and suggests some starting points. Duncan Jarvis, our producer, finds out more.
Spencer, thank you so much for joining us on the podcast. Could I get you to introduce yourself, please?
Thank you for having me. My name is Spencer Murch. I'm a psychologist and a postdoctoral fellow at the University of Calgary in Canada.
And one of the authors of this new analysis just published on bmj.com, Online Gambling Requires Greater Government Regulation, which I feel like is a call that we hear about a whole bunch of industries at the moment. But I wanted to start, Spencer, by asking you about the onlineness of gambling. Is that particularly problematic? Is it a multiplier here?
The easy access of online gambling is a particular concern to psychologists and gambling researchers like me, not just because it makes it very easy to engage with the activity in the first place, but also because if you're somebody who has engaged with the activity, who has begun to experience some problems, and who's now trying to cut back on your gambling, these advertisements, these inducements, whether it's promotional offers arriving as push notifications on your phone, or merely a persistent presence of gambling-related imagery on the sport broadcast that you enjoy, for example, these things make it a little more difficult to cut back and make it more likely that you may relapse into gambling problems. We understand across substance-related and behavioral addictions that cues, visual cues, stimuli related to addictive products aggravate the risk for relapse into use of those products. And so gambling advertisement is a particular concern, not just because of the way that gambling activities may be expanded, but in particular, it's about minimizing the risk for relapse among people who have experienced gambling problems and who are trying to cut back and who are trying to maintain remission from gambling problems.
Yeah. You mentioned there the imagery that can be triggering in gambling, and those adverts look great. They're flashy, and then we'll come up with a little message saying, gamble responsibly.
On their face, these messages seem a little bit unbalanced with the amount of effort put into the promotion side. And this is, in general, across multiple jurisdictions, this is the kind of thing that we will see where a government will task a regulator with reducing the risks associated with gambling. And typically, the rules that are in place will say something like regulators will require, as a condition of being licensed, operators, when they do advertise, will have to include a responsible gambling message. But crucially, they very rarely provide additional information about what exactly that message should say or should do, and leaving a lot of leeway to the operators to decide exactly how to roll out that message puts the message itself, the harm reduction message, in direct conflict with the profit promotion side of doing that advertisement in the first place. And so within licensed operators, you have an inherent conflict deciding how effective to make your harm reduction message in the context of your profit promoting message, or how effective to make your profit promoting message compared to your harm reduction message. And what we've argued in the piece is that governments facing the new reality of an increasingly online and increasingly harmful gambling environment need to take more steps towards clearly defining what these need to be. These messages, rules around how much a person is allowed to spend, or how much they can engage in online gambling before an operator must check in on them to see if things are going wrong for that person, if that happens at all. We've argued in the piece that governments need to take more direct action in clearly defining what harm reduction looks like to them. Because left to gambling operators, we've seen too many examples where harm reduction efforts are left behind or allowed to lag behind while profit promotion continues apace.
For someone who feels like they might have a problem with gambling, there are effective ways to reduce that risk. One of them being self-exclusion. And before we started our recording, you were telling me about what's happened in Ontario to neuter that potentially very effective intervention.
Yes. So in Ontario, Canada, in 2022, the provincial government made the decision to allow private sector online gambling companies to begin operating. And what happened at the time was the province's existing self-regulation system, which for people who are experiencing gambling-related problems, self-exclusion is just one of the tools that they can use to try and reduce their gambling going forward. It, in most cases, in most parts of the world where you can find a self-exclusion program, it involves a registry or a list that you can put your name on, and then gambling operators who have that list are not supposed to serve you. You're not supposed to be allowed to gamble. And Ontario had one of these systems related to online gambling when they were a state monopoly and they had just the one gambling website. But what happened when dozens of new private sector operators arrived in the province very suddenly, began advertising, began selling their products, is now everyone who may be experiencing gambling problems and who may want to reduce the risk of continued gambling by signing up for a voluntary self-exclusion program, now there's not just one place they have to go in order to make that happen. They would have to go to each operator individually to sign up. And now more mature gambling markets, places like the UK, have in place cross-operator self-exclusion, where you can sign up at just one service. In the UK, I believe it's called GamStop. And this is supposed to prevent you from being able to access all of the licensed gambling opportunities. Ontario, now 4 years after opening its market, is still struggling to put in place such a system. And the effect that this has on people who had or who have developed gambling problems in the province is not just that it's very difficult to make self-exclusion work in the province now, it's also that anyone who was on the self-exclusion list in the province when the market opened up, suddenly there are dozens of new operators in the province, and they're grappling with that. And so this is part of the reason why in Ontario we've seen a 40% increase in helpline call volume since before the pandemic. And we've seen a quadrupling of gambling-related bankruptcy declarations in the province.
I mean, it seems like very often when there are changes in this legislation, it's sort of framed much more around the business opportunity and maybe less thought about public health and balancing those two things together.
So when we consider what it means to put public health first and profit promotion second, we should be taking a hard look, not just at the existing system, which has emphasized onshoring online gambling activity in order to tax and regulate it, in order to then take those tax proceeds and try to address gambling-related harms, we should recognize as well that a huge portion of gambling proceeds come from a vital few, very highly engaged gamblers who research shows are the most highly at risk for harms. And we should question whether it makes sense to us from a regulatory level, from a legislative level, or even just from a human level, to try and solve the problem of online gambling harms using proceeds that come in large part from people who gamble online and are being harmed.
Well, you mentioned there that there is some legislation going through Parliament in Canada re-looking at this and trying to solve some of the problems. And you've set out perhaps some of the things that we know. Do you feel confident, or how are you feeling about the future of gambling regulation in Canada and around the world?
I think that positive change is coming and is being seen in a number of key jurisdictions. The crucial thing around the world is for us to craft a more rigorous government response to online gambling that is consistent not just across the ways that people gamble, not just that is dialed into the level of harms that we're seeing for different gambling formats, but that is consistent with other legal but addictive products, right? So gambling policy should be, when we consider advertisement and sale, should be similar to how we consider the advertisement and sale of tobacco, of cannabis, of alcohol. And this is going to involve bringing together a more fulsome, a more thoughtful regulatory approach.
So you're not saying here to go back to prohibition of gambling. It is really about effective regulation.
It's about considering gambling regulation in the context of not just our evolving understanding of what gambling means, right? Many laws governing the advertisement of gambling may have been put in place at a time when the only gambling being done was charitable lotteries. And now we're in a world of online gambling, daily fantasy sports, e-casinos. There may be a mismatch between existing laws and what is needed today. So I'm not saying that we need to get rid of gambling. Quite the opposite, in fact. People should be allowed as adults to choose to gamble if they wish to. What I am saying is that responding to the unique challenges posed by online gambling, now understood to be an addictive thing, requires a greater government response.
And that analysis, Online Gambling Requires Greater Government Regulation, is now available on bmj.com. That's it for this week's episode. Next week, Cameron will be back hearing about how the internet has hijacked our health. I'm Navjot Lada. Thanks for listening.